So, on behalf of Indian Academy of Neurology Movement Disorder Subsection, I welcome everyone on the occasion of World Parkinson Day, which is on 11th of April, and that is basically marked as the birthday of great neurologist James Parkinson, who first described the clinical features of Parkinson disease. And we are going to have some talks regarding Parkinson disease. And to carry over the program, I request our Secretary, Movement Disorder Society of India and convener of this Indian Academy of Neurology Movement Disorder subsection, Dr. Ravi Yadav, who is a professor of neurology at NIMHANS. Dr. Ravi.
Yeah, thank you, Dr. Sanjay. So it is indeed a pleasure to uh, conduct this program on the occasion of World Parkinson's Day. And I'm thankful to IN office bearers, Dr. Sangeeta Rawat, Dr. Meenakshi Sundaram, and all the EC members for giving us the opportunity to uh, hold this program on behalf of IN Movement Disorder Subsection. We have been doing a lot of activities last 1 year, and as you all know that we did bi-monthly case discussions, and where we did different medical colleges were taken from Jaipur, eastern part of India, southern part of India. So that also we are going to soon initiate as part of the subsection activity. And to take forward today's program, we have our uh, two coordinators, Professor Neeraj Kumar, who is Professor of Neurology and Movement Disorder Expert at AIMS BB Nagar. And he has 88 publications in peer-reviewed journals, several book chapters, and very active in leadership positions in various movement disorders committees. Then we have Dr. Divya, Professor Divya from Sri Chitra Tirunal Institute. And she also has a very avid writer. She has published more than 132 publications, and also in various high positions and leadership positions in movement disorders as well as neurology. So I invite Dr. Neeraj and Dr. Divya to take the program forwards and also introduce the next speakers and how they are going to carry.
Thank you, Ravi boss. Thank you, Sanjay boss. So, we had tried myself and Divya. What we have tried to basically make this program case based, and all the speakers will discuss case based and highlight the learning points based on the cases. So we will start without much ado, and I will request Divya to kindly invite the first speaker. Divya, please.
Yeah. Thank you, sir. So what we are going to do in the next 1.5 hours, we are going to deal with Parkinson's disease management in a case-based approach. So first, to start the topic, we'll start with the diagnosis of Parkinson's disease. This will be handled by Dr. Dhruv Batra. He's a consultant neurologist and movement disorder specialist at Viveka Hospital, Shantiniketan, Nagpur. And he's interested in movement disorders with special interest in botulism toxin therapy, DBS, and preventive neurology. He has multiple accolades to him. So, Dr. Dhruv, over to you.
So I'll just share my screen. Yeah. So is it visible?
Not now, Dhruv.
Just
You
one
have to
minute.
hit
Asmita?
the share button on the menu bar of the below thing.
Just one minute. So entire screen. Yeah, 1 minute.
Yeah, it's coming out.
Yeah. So this
Yes.
visible now?
Yes, Dhruv, we can go
Yes, put it on
to. Yes, perfect. You can start.
Perfect. Yeah. So I think we have limited time. I think about 12 minutes. So I'll quickly, start off and first come to straight to the point is the diagnosis of Parkinson's disease. Now, Parkinson's disease has a diagnostic criteria. So we should all know about the criteria, because otherwise there will be many wrong diagnoses. Many patients who are not Parkinson's disease, they will be included within this ambit of Parkinson's disease, and they may be atypical or not exactly Parkinson's disease. We know that it is a very common form of Parkinsonism. More than 6 million people have it worldwide. So the diagnosis of Parkinson's disease depends on history and examination. History can include prodromal features, the RBD, the hyposmia, constipation. It has the characteristic movement difficulties like tremor, stiffness, slowness, and psychological and cognitive problems like cognitive decline, depression, and anxiety. And examination will demonstrate bradykinesia, tremor, rigidity, or both. And nowadays, in the diagnosis, tests are also included, like a DAT scan, which can improve the accuracy of diagnosis when the presence of Parkinsonism is uncertain. So briefly, these are the signs that we are looking for in Parkinson's disease: bradykinesia, rigidity, rest tremor, and postural instability. And these are the non-motor findings that we are looking for: olfactory loss, sleep dysfunction, autonomic dysfunction, psychiatric disturbances, cognitive impairment, and other features like fatigue, hypophonia, sialorrhea, and trouble while swallowing. Now, what is not very clear is what is the diagnostic criteria. How can you ensure that you are really dealing with Parkinson's disease? So the first thing that you should know is that there is an essential criterion, which is the presence of Parkinsonism. So which is defined as bradykinesia in combination with at least one of tremor or rigidity. So many times it is a concept that, tremor is the predominant finding in Parkinson's disease. No, the essential criteria is Parkinsonism. So you need to demonstrate bradykinesia in combination with at least rest tremor or rigidity. So this can be easily done on examination. And once that is done, then you can proceed to diagnose whether it is a clinically established Parkinson's disease or a clinically probable. We'll come to that. So before we come to that, we should know what are the supportive criteria. So the first thing you should know is essential criteria. That is the presence of Parkinsonism, which means bradykinesia and either one or more of rigidity or rest tremor. After that, you should know what is the supportive criteria. This will be useful when you are using it to define clinically established or clinically probable. So what is the supportive criteria? That there should be a clear and dramatic beneficial response to dopaminergic therapy, number one. The presence of levodopa-induced dyskinesia, that's number two. Third is the rest tremor of the limb. And fourth, which is very interesting, is the either olfactory loss or a cardiac sympathetic denervation on MIBG. So the MIBG scan now is a part of the supportive criteria. So these are the four supportive criteria that you should always know. Now, absolute exclusion criteria. Why this is important is, it may not be easy to remember this at the first go, but if you have this checklist in front of you, if you find any one of the findings within this list, your diagnosis of Parkinson's disease is absolutely ruled out. So the presence of cerebellar signs, any downward or downward vertical supranuclear gaze palsy, any evidence of a probable behavioral variant of frontotemporal dementia or primary progressive aphasia, or Parkinsonian features limited only to the lower limbs for more than 3 years, presence of treatment with a dopamine blocking agent. So in the presence of tetrabenazine or presence of risperidone, you cannot diagnose Parkinson's disease. Absence of a response to levodopa, you're giving high dose of levodopa and there is no response. And presence of cortical signs like astereognosis, graphesthesia, etc., or a normal functioning neuroimaging, or documentation of an alternative condition. So this is an exhaustive list, but you should have this in front of you. Any of this which is present, your diagnosis of Parkinson's disease is ruled out. Now coming to red flags, I'll quickly go through this so we can see some videos and cases. Rapid progression, complete absence of progression of motor symptoms, early bulbar dysfunction, inspiratory respiratory dysfunction, severe autonomic failure. These are all red flags. And I'll come to the importance of this in diagnosis. Recurrent falls, disproportionate anterocolis within the first 10 years, or any absence of common non-motor symptoms like RBD or constipation, hyposmia. These are all red flags if you are looking for Parkinson's disease. And pyramidal track signs and symmetric Parkinsonism is something you should be very careful. So if you have to diagnose clinically established PD, you should have absence of all the exclusion criteria, and at least 2 supportive criteria should be present, and there should be no red flags. And if you are looking at clinically probable PD, Again, there should be no exclusion criteria. Absolute exclusion criteria should be absent. There can be red flags. So, for example, a rapidly progressive Parkinsonism, but then you should also have one supportive criteria to negate it. So, two red flags, it should have two supportive criteria in presence, so that then you can call it probable. So, I think we'll skip this part. So, in brief, for people who are looking to briefly discuss how do you diagnose Parkinson's, always look for a prodromal period. That look for early signs like RBD, which comes up to 30-40 years before the development of motor signs. Look for autonomic signs and hyposmia, and also look for a family history of Parkinson's disease. If there is a family history of Parkinson's disease and the patient now has hyposmia, then this is a chance that this patient may develop Parkinson's disease. And in the diagnostic period, when you have motor signs, then you should look for, as we said, Parkinsonism, and then you should look for supportive signs. Then you should rule out the absolute exclusion criteria, and then you should look for red flags. So if you go in this pattern, you will be able to diagnose whether you are dealing with Parkinson's disease. And nowadays, investigations like a TRODAT scan and genetic tests are also included in the diagnostic criteria. So, briefly coming to this slide, in the presence of a dopamine blocking drug, in the presence of symptoms only limited to the legs for 3 years, in the presence of a gaze palsy or cerebellar findings, you can never diagnose Parkinson's disease. So I'll quickly, this is a quick examination which can help in diagnosing Parkinson's disease. If you see on the right hand of the screen, you have, a micrographia while drawing the spiral, whereas in a dystonic tremor, it is, nearly similar. And you can see the spiral when we draw, it is, micrographic. It tends to reduce in size. This is the TRODAT scan. If you look in the top of the screen, this is a normal TRODAT scan where there is a normal binding of the iodine 123 dye to the dopamine receptors, and in the lower half of the screen you see that there is reduced uptake bilaterally asymmetrically in the putamen. So this is basically Parkinson's disease, and this is a normal TAT scan. MRI can also be useful to diagnose, differentiate Parkinson's from secondary Parkinson's or atypical Parkinson's. So for example, this is MRI SWI sequence, susceptibility weighted imaging. So this is what you see is a normal swallowtail sign on an MRI. So this is the tail of the swallow. So the absence of this swallowtail, remember this, the absence of the swallowtail, if you can see here in the red arrows, is suggestive of depletion of the nigrosome in that area, and which is suggestive of Parkinson's disease. Usually it will be asymmetrical. If you see something like this on an MRI, which you would call, hummingbird sort of a sign, where there is a midbrain atrophy, and you measure the pons to midbrain ratio. So this would be more typical of a PSP. If you see a hot cross bun, as you can see here, this would not be likely seen in a patient with Parkinson's disease. And this is the latest scan, which is why this is important, is because this is now one of the supportive criteria. I'll quickly go through it. If you see the normal control, you see the dye uptake is there in the heart. So this is the heart where you can see the red arrow. So these are the normal controls on the right hand of the screen. So the uptake is normal in the heart, which you can see here normally. But whereas in Parkinson's disease, it is not there even after 24 hours. So what this means is that in Parkinson's disease, the preganglionic and the postganglionic neurons are, degenerated. So the dye cannot be up, it does not get uptake, and it doesn't go into the heart. It is a proof of degeneration of the postganglionic neurons. So this proves very specifically Parkinson's disease, whereas in MSA, you will see it as normal because the postganglionic neurons are intact in MSA. So we'll quickly see some videos and I'll wrap up in a couple of minutes. So this is RBD. So this is something which is, a prodromal manifestation. Somebody, 30 years before development of motor symptoms will have a dream and nightmares during the sleep. You can see that he's shouting, he may fall off the bed, he may injure his partner. And this is a prodromal sign which should never be missed, because these patients can eventually develop Parkinson's disease. So this is a young patient, why I have, yeah. So this is a young patient. You can see she has these rest tremors, left more than right. Why this is important is this patient may have a genetic diagnosis. You should very carefully ask for family history of these patients. You should look for KF ring. In this patient did not have it. You can see that I'm looking for it. So this patient did not have it, but you should look for KF ring in any young patient with Parkinson's or any family history of Parkinsonism. This is what is this video is something which will help you to sort of differentiate between typical and atypical. So this lady with Parkinsonism had, you can see this orofacial dyskinesias and dystonias. So this is very typical of patients with multiple system atrophy type P, because they develop this early in the course of the disease. So this can be a clue that you are dealing with atypical Parkinson's. One more patient with atypical uh, Parkinson's. Just look at her. Uh, she has this. She has this anterocollis. You can see that the neck is flexed forwards. So this is an anticollis very early in the illness, which is very typically seen in MSA type P. And if you look at her feet, you can see that she's developed, this at her hands. This is polymini myoclonus, which is seen, especially a postural polymini myoclonus, which is in patients with MSA. So if you have these type of findings, I don't think you are dealing with a Parkinson's disease. If you look at her feet, you can see that she has developed, early dystonia and sort of contractures in the legs. So this is also a sign that you're dealing with MSA and not typical Parkinson's. Quickly come to the end of my presentation. I think last two videos. So this is somebody with PSP. If I ask him to close his eyes, and while opening, he's just unable to do it in the beginning. So this is what we call the eyelid opening apraxia. So this is very typically seen in patients of PSP and not in Parkinson's disease. And lastly, you can see that this is a young boy. He's having slowness of walking, gait instability. He also had bradykinesia, rigidity. So a young child with Parkinson's disease, always and always, apart from a genetic background, apart from family history, you should always be very careful about history of other movement disorders in the child, because his father had chorea, and that was Huntington's disease, and a juvenile Huntington's disease can present with Parkinsonism rather than chorea. So I think I've come to the end of my talk, in given the limited time frame. But what I would like to suggest is that the diagnosis of Parkinson's disease, a clinical criteria, the knowledge of the clinical criteria is a must. You should always and always look for absolute exclusion criterias, and you should always look for red flags. In the presence of these, you should not diagnose Parkinson's disease. And to diagnose Parkinson's disease, you need essential criteria, that is Parkinsonism, and then you need supportive criteria as well in the absence of exclusionary criteria. Thank you very, very much for your time, and I'm sorry if I've exceeded my time limit.
Thank you. Thank you. So it was very talk, and the main message which you had gave, that must have gone well to all the listeners, that you have to have bradykinesia, and without that you cannot diagnose Parkinson's disease. And of course, you had pointed out several other nuances. So we'll come to that, and I request you to be there for the question answer session. And with that, we will go to the next speaker. And next speaker, Asmita, can you put the CV, please? So, Professor Ajit Cherian, he is from Sri Chitra, Trivandrum, and he will be talking on, he has several accolades at his account. I'm going to go through everything. I think he is well known. So, Ajit will speak on early Parkinson's disease and its management. So, Ajit, please, you can go ahead.
Okay. Thank you for your kind introduction. So, if you can close the site. So, thank you for the kind introduction. So, I'll be talking about the management of early Parkinson's disease. So, if you look at disease management, it may not be as easy as it looks. It needs a lot of experience, and you need to see the person in toto. And as Dr. Dhruv has already pointed out, rule out the red flags that then you are really dealing with PD itself. So let's start with the case. So this is a 66-year-old gentleman. You can look at the video while I'm telling you the history. He had been symptomatic for 2 years. He has got rest tremor, slowness of activities, is depressed, drug name, symptoms recently affecting his activities of daily living. And if you look at this video, you can see the tremor which is there. He has a mild stoop posture and he's quite slow. So this is one person that you may encounter in the day-to-day practice. And what will be the best option in this gentleman? You may start levodopa, start pramipexole, start romatrol, start MAO-B inhibitor like sertraline or rasagiline or start amantadine. So these are the options that is there in front of you. And I'll tell you another case that of a 43-year-old gentleman, symptomatic for 2 years. He has got stiffness of left shoulder, something like a periarthritis. He also has got rest tremor, slowness of activities of the left. He's depressed, was advised medication, still drug name, symptoms recently affecting his activities. So let's take these two case scenarios. And after my discussion, let's look at what will be the ideal approach in these two gentlemen. So the options are the same for this person also. So after the discussion, we'll look at what will be the ideal drug. So if you look at the gamut of drugs which are available, levodopa stands out. So levodopa, why do we give levodopa? Because dopamine, it poorly enters the blood-brain barrier. So it doesn't cross blood-brain barrier smoothly. So uh, levodopa is the ideal drug, and it's often combined with carbidopa because there are peripheral inhibitors which are there. So carbidopa reduces the peripheral destruction of levodopa. And once it's taken in, it is converted to dopamine. And the dopamine is metabolized by MAO-B inhibitors. And there are inhibitors for MAO-B, that is sertraline and rasagiline. And the newer drug in that combination is safinamide. And then you have the catecholamine O-methyl inhibitors also. And the other drug which can use in Parkinson's disease is dopamine agonist. Currently, only two drugs are in vogue. One is pramipexole and the other is ropinirole. Rest all have gone into disrepute because they are all ergot-based drugs. And if you look at a novel mechanism, amantadine is the other one, which increases the release, and it has got also various other anti-glutamatergic activities also. So these are the drugs that you have in the gamut. Now, levodopa is the most effective drug, and today it is considered as the gold standard. And other dopaminergic drugs also have a significant role. And non-dopaminergic drugs as add-on therapy are used to address the shortcomings of the dopamine-centered approaches. Now, you need to individualize the therapy at all phases. Age, comorbidity, symptom severity, potential adverse effect profile, all these come into play when you deal with what is the ideal drug that you are supposed to use. Always in the first few years, you get a good drug response and before the appearance of the motor fluctuations. So let's take the key drug, that is levodopa. The ideal ratio is always, with carbidopa, is always 4:1. The 10:1 combination is also available in the market, but that is not the ideal ratio. The ideal ratio is always 4:1. So the ideal drug is 125 milligrams strength, 100 by 25 strength. So it significantly reduces bradykinesia and rigidity, but efficacy for tremor is less robust. And the T-half is approximately 60 minutes, and multiple preparations are available. You have the immediate release and control release. Often we use the control release nocturnally at bedtime to avoid the nocturnal akinesia, as it has got a protracted duration of action. It is always better to start low and go slow. This reduces the side effects. Like any dopamine medication is bound to cause nausea, vomiting, giddiness, sleepiness. And in the initial phase, it may be a prudent technique to add a low dose of domperidone for the initial 15 to 20 days to avoid these side effects. Proton pump inhibitors will reduce the absorption of levodopa, so will multivitamins. So never combine these two drugs along with levodopa. Always give levodopa before food. Best to give it in an empty stomach, at least 1 hour prior to meals. And there are very significant food interactions. carbonated citrated drinks will increase the absorption of levodopa. So if you want a quick benefit of levodopa, it is always better to take in a carbonated citric acid drink, like a lemon juice with soda or something like 7-Up or will do. Other foods, especially protein-rich food, will reduce the absorption of levodopa, so it should never be given along with food. So this is something which you need to keep in mind. So always give 1 hour prior to each meal. So that's empty stomach is the ideal time. What are the long-term side effects? You can have a levodopa-induced hallucination, orthostatic hypotension, and as disease goes on, you tend to get motor fluctuations and dyskinesia. Longer duration and higher individual levodose predicts the incidence of dyskinesia. That is something which you need to keep in mind. And duration of levodopa has a lesser role to play in that. Now coming to the second type of drug, that is a dopamine receptor agonist. I told you 2 drugs are currently in vogue, that is pramipexole and propranolol. They directly stimulate the striate postsynaptic dopamine D2 receptors, and they tend to have a longer T-half than levodopa. And extended release preparations of pramipexole is also available. And we also have rotigotine patches which can release drug for almost 10 to 24 hours. And the quickest among this is apomorphine, where you can have sublingual as well as injection preparations are available. Now, if you look at dopamine agonists, pramipexole comes at the lowest strength is 0.125. So immediate release preparation. So always start with a very low dose of 0.125, and it is given 3 times daily, and slowly titrate it every week to 0.25, then make it 0.5, then make it 0.75 or 1 milligram 3 times. The maximum dose of pramipexole that is advocated is 4.5 milligram per day. Now, if you were to look at the side effects, both dopa agonists, that is either pramipexole or roperidol, can cause excess sedation, especially sleep attacks, impulse control disorders, leg edema, hallucinations, and sometimes orthostatic hypotension. So this is something which you need to keep in mind. Roperidol is also given 3 times, and the maximum dose of roperidol which has been advocated is up to 24 milligram per day can be given. Pramipexole has the added advantage that it also works as a very good antidepressant compared to propranolol. And when it is given, when dopa agonists are given as a monotherapy in the initial phase, it delayed the onset of dyskinesias by over a 3 to 5 year period as compared to levodopa. This is a very interesting finding, which is well known, which has come in this article which has been published in NEJM. So in very young individuals or early onset PD cases, especially in those less than 50 or less than 60, it may be a wise idea or prudent idea to start with monotherapy of dopa agonists rather than initiation with a levodopa in the early phase in this kind of early or juvenile PD cases. Now coming to the next set of drugs, that is the monoamine oxidase type B inhibitor. So 2 drugs are in vogue, that is rasagiline and selegiline. Rasagiline strength is 1 milligram, max dose is 1 milligram per day, and selegiline is 5 milligram strength, and you can give it a max dose of 10 milligram per day. The important side effect being nausea, dyskinesia, hallucinations, and lightheadedness. Now, they have a very prolonged they increase the levodopa action by irreversible MAO-B inhibition, and they improve the motor system. But it is overall inferior to levodopa or dopamine agonist as a monotherapy. Now, safinamide is a new drug. It is a reversible MAO-B. It has 1,000 times more specific for the MAO-B, but however, it is not indicated as a monotherapy in PD. So where you usually use safinamide is along with levodopa, especially when motor fluctuations and dyskinesia onset is taking place. That is the ideal time to introduce safinamide. Next group of drug is the anticholinergic, especially trihexyphenidyl. It has got a very good benefit on tremor, but the side effects are pretty huge, like especially in the elderly, cognitive impairment, constipation, urinary retention, and orthostatic hypotension are the important side effects of trihexyphenidyl. Now, if you are to use, if you are to take one of these preparations for the early therapy of Parkinson's disease, which one will you choose? From an efficacy point of view, levodopa scores over the rest of the other drugs, whether it's dopamine agonists or MAO-B inhibitors. But the side effects of levodopa are also higher. And when it comes to the motor fluctuations or complications, dopamine agonist has got a moderate advantage. So this is how the chart goes. Now, in elderly, the ideal drug is always levodopa, especially if the patient is over 65 years of age. We always start with levodopa. Very low doses, half tab, and then increase to half tab BD and half tab TDS, and then slowly increase to one tab TDS. However, in younger age, early PD and mild symptoms, dopa agonists are preferred. Among the dopa agonists, Pramipexole has a slighter advantage over Ropentrol, especially because of its antidepressant action. Levodopa is more efficacious, but the only issue is the long-term complication rates, especially the dyskinesia and the motor fluctuations, tend to be higher if a higher dose of levodopa is used for a longer period. However, if motor impairment is severe, levodopa should be preferred even in younger patients without delay. Because from an efficacy point of view, always levodopa scores over dopa. Always take into consideration other coexisting comorbidities like depression, cognitive impairment, and impulse control disorders. Now, I would like you to introduce this term of levodopa equivalent daily dose, also known as LEDD. Now, levodopa is considered as 100 milligram strength, and pramipexole 1 milligram is supposed to be equivalent to levodopa 100 milligram. Ropentrol of 5 milligram is equivalent to 100, selegiline of 10, rasagiline of 1, amantadine of 100, and safinamide, both 50 and 100 is supposed to be equivalent to levodopa 100 milligram. So this is the LEDD equivalent daily dose. Now, if you are adding entacapone to levodopa, the levodopa efficacy increases by 33% more. So if you are using 100 milligram with entacapone 200, the levodopa equivalent dose will be 133. So that is, but CR is only 75 milligram equivalent. CR, the equivalence is slightly lower compared to the immediate release preparation. Now coming back to our case scenario, the first case was that of a 66-year-old gentleman, symptomatic for 2 years, rest tremor, slowness of activities, depressed, drug need. So in this patient, elderly, the ideal drug is levodopa to be started, because especially if the individual is more than 65 years of age, it is always better to start the patient on levodopa. So ideally, I would start this patient on levodopa. Start him on a low dose. So never give a dose which is more than that what is really required. Many patients in the initial phases may be even comfortable with twice daily dose of therapy. Sometimes you may start with half tablet and then increase to half tab BD and then maybe slowly increase to one tab BD. Sometimes that is all that is required. There is no real requirement to give 3 times or 4 times. So one should prevent oneself from hiking up the dose if there is no real requirement for the individual. So always ask the individual, are you able to do your activities of daily living? Are you able to drive? Are you able to function without any issues? If that is so, prevent yourself from jacking up the dose unnecessarily. So that is something which you need to keep in mind. In the case 2, that is that of a 43-year-old gentleman, symptomatic for 2 years, rest tremor, depressed, I think I will start with pramipexole, because when you have a very young onset PD patient, I always prefer a D2 agonist. And if I have gone up to the maximum dose of D2 agonist, I have gone up to 1.5 milligram 3 times. And if this patient is still symptomatic, I will definitely start him on levodopa. That will be my way of approach. So to conclude, the management of Parkinson's disease is always individualized. So look at the motor as well as the non-motor symptoms. What is the most disabling stuff? So sometimes some patients may be actually better, the tremor may be the immediate problem. And in young individual, you may in fact add pacitine or trihexyphenidyl and jack it up. And that will be giving more benefit to the individual. So it is always an individualized approach. There is no hard and fast rule. And dopamine agonists are efficacious in early PD and should definitely be given in younger patients less than 65 years. levodopa need not be delayed when motor symptoms are disabling. So even if you have a juvenile PD, but if the motor symptoms are disabling, you initiate the patient levodopa simultaneously. So our aim is in management is to shift from a slow course to a fast-paced snail. So that is what we are aiming at. And thank you for your patient listening.
Thank you, sir, for that excellent presentation and, in fact, highlighting how the so-called very common drug levodopa is used, and as well as emphasizing on the due importance of a molecule like pramipexole, which is very much essential. Thank you very much. So, as the first honeymoon phase in Parkinson's disease management ends, the patient is back to us unhappy. So, to address the issues in the advanced management or advanced disease in medical management, I call upon Dr. Sirisha Yerida. She is an additional professor at Nizam's Institute of Medical Sciences. Her areas of interest are movement disorders and pediatric neurology. She is handling multiple projects on Parkinson's disease as well as movement disorders, and she has multiple achievements. So over to you, Sirisha.
Thank you, ma'am. At the outset, I would like to thank Neeraj sir and ma'am for giving me this opportunity to discuss today on the management of Parkinson's, the advanced Parkinson's stage. Can you see my screen, ma'am?
No. Please share.
Yeah.
Yes.
Yeah, thank you, sir. So, starting quickly, sir has nicely illustrated the early Parkinson's disease management. Now, what is the line between the early and the transition to the advanced Parkinson's disease? So, as per the Yin and the Yang staging, once the stage 3 and 4, that is, where there is a significant balance impairment, and those in the 3 and 4, where they are physically independent, and they after going to the stage 5, where they need a wheelchair or they are bedridden unless assisted. So this stage constitutes the advanced Parkinson's disease. Now, in what way are they different from the early Parkinson's disease? As you can see the timeline, as the time is passing by, the degree of disability is worsening. In addition to the non-motor symptoms, there is also the motor symptoms which have taken an equal part of complications impairing the quality of life. So in the advanced stage, that is both the mid stage and in the late stage, you can see that there is significant impairment due to postural instability, dysphagia, lot of deformities, axial deformities, camptocormia, falls, and issues with orthostatic hypotension, memory, hallucinations. So these these are a great challenge, and the issues are basically of two types. One is a motor complication, and the other one is a non-motor complication. The motor complications are something which we can see mostly in the form of on-off fluctuations, whereas the non-motor complications, which I just mentioned, are not eloquent, they're not generally seen, but they do contribute to a greater disability. Coming to the management. After years of treatment, it's known that the levodopa therapy is complicated by development of the motor fluctuations. The initial part, when there was a honeymoon phase and when there was a good response to the levodopa, where the options of the available treatment are many-fold. And as sir rightly mentioned, you have to start low and go slow. Here, the benefit of the drug becomes progressively shorter, and periods in which the patient responds to the drug become complicated by severe dyskinesias during the on state. So, let us discuss this entire motor fluctuations in the form of three major challenges which we face. One is the predictable on-off state. Here, coming to the case scenario, this is a 60-year-old lady who is a known Parkinson's since 8 years. Now she has progressed into the advanced stage where she has severe off state and early wearing off phenomenon. So whatever medication was giving, it's taking a very long time to act, and it's also not lasting for a longer period. So that was a motor issue which she was suffering with. And the attenders have complained that she's not becoming on like she was before. And even during the off phase, she has other non-motor symptoms and she was suffering with severe pains. It is very disabling pains, Sometimes she says that there are pains even over the head and face, which are very non-specific, whether it is a functional component, but they're sure that once she takes the medication, the pains are coming down. And there is excessive sweating, and she's very anxious during this off state. So this is a video of a patient, of this patient, where you can see that severe off-state dystonia. Here you can see that the leg dystonia, which is one of the important feature in the off-state, which is normally seen in Parkinsonian patient. So in the right leg, you can see that there is off-state dystonia. Similarly, in the legs, in the left leg, though she is in the off-state, she has certain ballistic movement where there is mild flinging movement. Coming to the gait, in the off state, there is slowness of her steps, there is short shuffling steps, and she has camptocormia and decreased arm swing in the left hand. So these are the issues with the prolonged off state. How do we manage such cases? It is similar to the wearing off effect or the end of dose echinacea, and the off state management is almost similar. Now, because she is off, you have to increase the frequency of levodopa. Now, how do you increase it? The increased dosage, but it comes at a compromise of dyskinesias. And we just heard that patients with advanced stage are prone to severe dyskinesias too. How to increase the levodopa efficacy? You can add enzyme inhibitors like COMT inhibitors and the MAO inhibitors, which facilitate the prolonged stay of levodopa in the body. The other advantage, like other mechanism where you can have a faster response, or in order to get a faster responses, add dispersible tablets of dopa, which can absorb fast and you get a faster effect. And then other method is dopamine agonist or switch over. You can try a combination of the other dopamine agonists, like from one to the other, you can switch over. But as I mentioned, there is an increased risk of dyskinesia. Some patients, particularly during night, they have difficulty because of the wearing off of the drug. They can have severe nighttime akinesia. In such case, you have to switch over to the controlled release form, particularly during night. The levodopa carbidopa controlled release formulation during the night takes care of the nighttime akinesia, which is a good practice point. And then it is also ideal to try amantadine and anticholinergic. But we all know that amantadine can worsen the risk of hallucinations, and anticholinergic also can worsen the risk of confusion. So with this tailor making to the patient needs, a combination of medication can be tried. There is also a role of subcutaneous apomorphine, levodopa carbidopa infusion gel, and deep brain stimulation. So this is a patient after undergoing the deep brain stimulation, where there was an improvement in her quality of life with an improvement in the off-state dystonia. And GPI-DBS is known to be anti-dyskinetic, and it has a beneficial effect on the dystonia too. So this patient underwent a GPI-DBS, deep brain stimulation, and she says there is a significant improvement, because this was fascinating that she had on one limb she had dystonia and the other limb she had hemiballismic dyskinetic movement in the off state. This is a second case where some of the patients who are on medication, they have severe dyskinesias in the on state. So here you can see these dyskinesias are described to be either they can be they can be ballismic, they can be coriform, sometimes they can be dystonic, or sometimes at times it can also be the myoclonic type. So it's a variable movement disorder which we see during the on-state dyskinesias. So this another lady who had very violent flinching movement. This was more ballistic type, and it was uncontrollable, and the patients attend us, and there is a risk of injuries, and there's lot of wasting and energy loss because of the violent dyskinesias. So in the off state, when we are trying to increase the medication, it might go into peak dose dyskinesias. So how do we tackle it? You can decrease the dopamine dosage. However, the problem is it might go again into the off phase. The solution to that is probably you can try to decrease the dosage, at the same time increase the frequency of the dopamine medication. You can add dopamine agonist like pramipexole, and you can add amantadine. We all know that amantadine is an anti-dyskinetic drug. So you can add amantadine. Studies have shown that the effect of amantadine lasts for less than 8 months. Long-term effect is not proven. And you can also add saponamide in case of dyskinesias. There are studies which suggested that you can give a levodopa drug holiday for 3 days, completely stopping cessation of levodopa infusion in levodopa tablets for 3 days, supplemented with IV amantadine infusion, is known to be beneficial for the peak dose dyskinesias. And the other methods are using apomorphine injections and levodopa carbidopa continuous intestinal gel infusion, and atypical antipsychotics like clozapine and quetiapine. Also, we have to be careful when we are giving these medications. Clozapine, we know, it's known to cause this wet pillow syndrome, where there can be continuous drooling. It can also cause agranulocytosis. Therefore, monitoring should be very, very meticulous. Every 2 weeks, we have to check for the complete blood picture. So these are the two major complications in the motor, that is the off state, and in the on, the dyskinesias. The third complication which we commonly encounter is the freezing of gait. If the patient says that there is an off state freezing of gait, it's very easy. You can increase the dose of the dopamine medication. It is similar to managing the off state, where you like wearing off phenomenon or a delayed starting up, where you increase the levodopa. However, the problem occurs if there is a freezing of gait in the on state, which is very refractory to treatment. There are studies which suggest that amantadine is helpful in, it is a medication which is helpful in the freezing of gait. However, when we give amantadine, the problem with amantadine is it can worsen hallucinations. Normally, what are the type of hallucinations which we see in Parkinsonism? They are normally the presence hallucinations. They feel that they are visual hallucinations. That is, as if there is some person near the side of their glasses, and they tend to turn the eyes and the head to look at the person who is nearby, and it looks like reflection of the light on the glasses, as if some person is there in the room. There is some people or thieves trying to open the door, or some people behind the curtain. So the important thing in this non-motor problem, which is very troublesome, is you decrease spasticity. You can try hexapentil, and also try to decrease amantadine, dopamine agonists, MAO inhibitors, COMT inhibitors, and DOPA, levodopa, in this order. We routinely add quetiapine and clozapine. Never give other antipsychotics, because though it is tempting, risperidone or olanzapine, which can cause metabolic syndrome, they should never be used in Parkinsonism, because it can worsen the Parkinsonism. The other problem, the non-motor problem, which is seen in advanced stages at the sleep, they normally have trouble staying asleep, not the falling asleep. So they fall asleep in their usual time, but they're off at around 2 to 3 a.m. in the morning, and since then they're not able to fall asleep. So is it a non-motor symptom of Parkinson's, where you have to increase the levodopa dosage? It's something like an off state. The peak levodopa is known to cause sleep, whereas in the off period, it causes insomnia. So you can ask the patient to have a pill just near the bedside, where they can immediately release levodopa, or you can use a controlled release tablet during the night, which helps in maintaining them to stay asleep. The other problem is the restless leg syndrome, which can be at times very disabling. We have to be careful to look for the other causes like anemia, iron deficiency, renal disease in them. In addition, the management, as we know, is a pramipexole, which will be helpful in the restless leg syndrome. So this is a patient who was having significant freezing of gait in the off state. So he has short shuffling steps, start hesitation, and camptocormia. In those patients, if at all it's like an off state, in the on state, the gait, by adding dopaminergic agonist or dopamine itself, it can significantly improve, and this is amenable to treatment. However, if the same patient would have had the freezing of gait in the on state, it is not possible to treat it. There is a lot of role of the visual and the auditory cues, which are the non-pharmacological methods, particularly the visual cues by using some LED flashlight, which gives him a cueing to walk and take the next step forward, whereas the auditory cues are mainly in the form of tap. So rhythmic taps which facilitate him to walk, which are available now in the form of apps, which they can use, something like metronome, where it gives a rhythmic beating, facilitating the patient to take the step forward. So these are the motor complications which have to be remembered in the advanced stage. And I'm sure there is a extensive session in the non-motor symptom management. So I just touched on few of the common non-motor symptoms in the period. With this, I would like to thank one and all for the patient listening.
Thank you, Sirisha. It was an excellent talk, and basically with the different cases you have shown, I think it must have gone quite well with the listeners. So please be available for the question answer session, and we move on to the next talk, and that is on the advanced Parkinson disease, where the surgical management comes into picture very oftenly at times. And Sirisha has just touched that topic with one of her cases. And now we have Dr. Sahil Mehta, who is a senior faculty at PGI Chandigarh, and he has several publications. Is quite active in the Movement Disorder Society forum. So Sahil, please, you can start your talk. Thank you.
Good evening, everyone. Thank you, Neeraj, for the nice introduction. Are my slides visible?
No, no. Please share the screen, Sahil. Yes, you can go on to slideshow. Perfect. Please go ahead.
So I'll be mainly dealing with the surgical management of advanced Parkinson's disease and will focus my talk on deep brain stimulation. So as you all know, deep brain stimulation is a surgical technique in which we implant electrodes in specific regions of the brain. And for Parkinson's disease, mainly subthalamic nucleus or globus pallidus interna. And there is a impulse generator is implanted in the subcutaneous tissue below the clavicle and which generates high frequency electrical stimulation to modulate or disrupt abnormal oscillations within the target region. And as compared to ablative procedures, deep brain stimulation is reversible and adjustable. This was first performed by Professor Benavit in 1987, and it involves multidisciplinary teamwork involving a neurologist, especially a movement disorder neurologist, a functional neurosurgeon, a neuropsychologist, and obviously the physiotherapist and occupational therapist. So this is a very important slide as far as deep brain stimulation is concerned. As was demonstrated by the previous speaker, the natural history of the disease and in the early stage when there is a honeymoon period, when you have good response to medications. But 5 years down the line, especially in the mid stage of the disease, when patients tend to develop on-off fluctuations, wearing off, delayed on, and other complications of dopaminergic treatment, dyskinesias, this is the time when we should go for DBS, as if the time is exceeded and we go to the late stage of the disease and the patient develops posture instability, gait disorders, falls, axial problems, dysphagia. So these symptoms do not usually respond to DBS. So when the patient starts to develop fluctuations and dyskinesias, then we should always refer the patient for the surgical treatment. And if these symptoms are not well controlled by medications. In PD, this DBS was first FDA approved in 2002, and then on the basis of early STIM trial, and it was approved even for early stage disease, especially the disease should have crossed 4 years in 2016. So the selection of patients is very important. It is very paramount. Duration disease of 5 years is important. This is important because it allows atypical features to emerge and the response to dopaminergic therapy is assessed. And secondly, dopaminergic responsiveness is very important. We always do a levodopa challenge test when we select the patients and to see if there is more than 30% reduction in the motor UPDRS3 scores, if there is history of troublesome dyskinesias, on-off fluctuations despite optimal medical therapy, with one caveat that despite this, if there is a disabling medication-resistant tremor. So these are the main PD patients who should be counseled and should be selected for deep brain stimulation. The patients with atypical Parkinsonism, PSP, MSA, the absolute contraindication and DBS should not be offered to these patients. And presence of severe dementia and uncontrollable psychiatric disorders, which is not controlled on treatment, severe depression, history of suicide tendencies, these patients should also not be encouraged for deep brain stimulation. So the good candidates are who have adequate response to dopaminergic therapy with the presence of on-off fluctuations, dyskinesias impairing quality of life, or presence of medication-resistant tremor, but they should have a reasonable cognitive function. However, poor candidates include presence of severe dementia, severe autonomic dysfunction, severe axial symptoms, freezing of gait, poor dopaminergic response to the treatment, atypical Parkinsonism, and even absence of a dedicated caregiver. The possible mechanisms, it is not entirely clear, but they say it disrupts the network jamming, causes depolarization block, and there are many hypotheses, but it is not entirely clear. So this is just a figure which shows the various steps in the process, which is mainly done by the neurosurgery team. And they mount the frame, then we do the MRI. The pre-op planning is done with the target visualization. And in the OT, we do the microelectrode recording and macro stimulation. And finally, the target, the DBS is implanted. And on the right side, you can see the various types of electrodes which are used, the conventional quadrupolar electrode. And nowadays, there are directional multipolar electrodes and even other types of electrodes. For PD, the predominant targets are subthalamic nucleus or globus pallidus interna. This is the microelectrode recording in one of the patients during surgery, and we see the activity from the subthalamic nucleus, and we know that we are in the target. So the most responsive symptoms, I'm again highlighting this tremor, rigidity, bradykinesia, dystonias, on-off fluctuations, and there is decrease in the medication burden. Possibly responsive is gait, especially if this responsive to levodopa and the gait improves with levodopa. However, freezing, postural instability, and cognitive decline do not respond to DBS. In the post-procedure phase, programming is usually started 3 to 4 weeks after the surgery. Patients are usually called in an off state. And then we see the response depending upon the site which has to be stimulated. Initially, there's monopolar configuration. The usual frequency is kept at 130 Hertz with pulse width of 60 Hertz, and the current is gradually built up. And it takes around 3 to 6 months for the complete programming, and patient is usually called 2 to 4 weeks, depending upon the response. This is an old programmer. Now we have new programmers also, which are iPad based. The side effects include, they can be surgical, they are not that common. ICH can occur around up to 4% cases, infections can occur around 2%, seizures can occur, then there can be device malfunction, but these are very rare. Stimulation-related side effects are also seen, especially stimulation and induced dyskinesia, weight gain in the long term, and some amount of speed change and decrease in verbal fluency, with some cognitive problems which can emerge even after DBS. And certain patients can develop gait problems even after DBS. So I'll just go through a few of the cases which we have done recently. This was a 52-year-old policeman who had young onset Parkinson's disease. His age of onset was 44 years, and he had predominant akinetic rigid syndrome. And despite all the medical treatment, he had wearing of on-period dyskinesias, and his almost levodopa equivalent daily dose was more than 1400 milligram per day. And this was a patient in the on phase. There was significant improvement. UPDRS part 3 in the on period was around 10. He had little bit of dyskinesias, not prominent. He was mainly bothered because of his gait problems and on-off fluctuations, and he was not able to perform his duty as a police officer. So he opted for DBS. And this is 1 year follow-up. He underwent bilateral subthalamic nucleus stimulation. He still has some problems, but we are managing him. And his requirement of levodopa equivalent dose came out almost 50% reduction in the medicines. There's another patient, 67-year-old female with age of onset at 60 years. Again, similar indications of on-off fluctuations with prominent dyskinesias. She was mainly bothered because of her off-period pain. And despite optimizing levodopa and other therapies, we were not able to manage his pain, and she was quite disabled because of her pain. This is the patient at 7 months follow-up. And she was happy as her pain remarkably improved after DBS. And there was significant reduction in the requirement of dopaminergic treatment. So DBS sometimes not only helps motor symptoms, but some of the non-motor symptoms can also be helped. And this is a recent patient which we done in January. She was 15 years duration. Again, on-off fluctuations, unpredictable dyskinesias.
So,
She also had history of psychosis, which was controlled with pimavanserin before we resorted her to deep brain stimulation surgery.
so
And this is at 3 months follow-up. The on-off fluctuations are remarkably reduced, and we are reducing her levodopa dosage. She's just on half tablet now, TDS, and she's doing fine. So my take-home message would be that it is not a curative therapy, and there is a mnemonic DBS in PD that it does not cure. Bilateral DBS is often required. It smoothens out the on-off fluctuations. It improves tremor, rigidity, bradykinesia, and dyskinesia. It never improves symptoms that are unresponsive to the best on. And programming visits are likely multiple times in the first 6 months of surgery. And there is a reduction in the medication in many, but not all patients. So it is a promising treatment. However, gait and posture instability and cognitive impairment do not respond to stimulation therapy. So a proper selection of the candidates is paramount for DBS surgery to be successful. Thank you.
Thank you, Dr. Sahil, for that wonderful elaboration on the surgical management of Parkinson's disease. The management of Parkinson's disease is incomplete, inadequate, and far from comprehensive without addressing the non-motor symptoms. To enlighten us on the non-motor symptoms of Parkinson's disease, today we have Dr. Divya MR with us. She is the Associate Professor, Department of Neurology at All India Institute of Medical Sciences, New Delhi. She has recently done her PDF from Center of Excellence for Parkinson's Disease at Bangkok. Over to you, Divya.
Is my screen visible?
Yes.
Okay, thank you. Thank you so much for the kind introduction. So in the next 10 minutes, we will be trying to see the management of non-motor symptoms in Parkinson's disease. As we know, the list is quite exhaustive. So we will try to see the major non-motor symptoms and the tips and tricks to manage those. Okay. So we know that Parkinson's disease comprises both motor and non-motor symptoms. So look at this figure. So we will be amazed to see that almost all body parts are affected with non-motor symptoms in Parkinson's disease. So we can actually divide them into major 4 groups like neuropsychiatric manifestations, sleep disorders, autonomic symptoms, and sensory symptoms. What is more fascinating is that many of these symptoms starts in prodromal stage, some even before the onset of the motor symptoms, and they very slowly progress and accumulate gradually and cause more disability. And it is important to know that we often talk about motor symptoms and often forgets about non-motor symptoms, and it is often under-recognized and underreported. And we know that many of these symptoms actually not related to the dopaminergic loss and are not responded to the dopaminergic therapy. However, a few symptoms like pain, sleep, and restlessness, cognition can actually respond to dopaminergic therapy and can have non-motor fluctuations too. So we will quickly go through a few of the non-motor symptoms and try to see how to manage them. So let's see the neuropsychiatric symptoms first. The common neuropsychiatric symptoms are anxiety, depression, psychosis, and some impulse control disorders. So let's see one by one. So anxiety is very prevalent in Parkinson's disease, and it comes up to 40% of in total. And most patients will also have depression, and it's vice versa. That means people with depression will also have anxiety. And you can see almost all type of anxiety in patients with persons living with Parkinson's disease. Like there can be generalized anxiety, social anxiety, some obsessive phenotype. And also sometimes people can have anxiety attacks. This may be actually non-motor fluctuation in the setting of a wearing off. So it is important to recognize these and manage this. So far as management is concerned, there are no controlled trials specifically to address the management of anxiety. So the first line management still is SSRIs and SNRIs and the benzodiazepine. So one has to be aware of the side effects also, including sedation and the deterioration in the cognition and balance and gait when using benzodiazepine. And preliminary results shows that cognitive behavioral therapy is also useful in managing panic attacks. And as we know that depression is also common, and it can be mild depression and major depression, and it can be again account up to 40%. And major depression is quite common and sometimes seen up to 20% of persons living with Parkinson's disease. And it is important to see that many of the other symptoms like sleep disturbances, appetite loss, apathy, and all these symptoms actually overlap in an otherwise Parkinson's disease person. And so it is important to recognize its symptoms. So if you suspect a person with Parkinson's disease having depression, count these symptoms towards depression and manage. That is the good clinical practice point that we usually do when we try to manage depression. So what are the risk factors in causing depression? So study shows that female gender, increasing age, and the personal and family history of depression and other medical condition are the usual risk factors. And the impact of deep brain stimulation on depression is not very clear, but on a general rule, usually the mood improves after the surgery. And it is clearly not known that whether the target GPA is better than subthalamic nucleus. It is still under debate. So how to manage? So we have both pharmacological therapeutic option and non-pharmacological option. So the proven efficacy in Parkinson's disease is for pramipexole, which is a dopamine agonist, as Dr. Ajit said in his lecture. And the other SSRIs and SNRIs are also useful. And venlafaxine has proven efficacy in Parkinson's disease. And possibly useful drugs are like tricyclic antidepressants. And other SSRIs and SNRIs like sertraline, paroxetine, and fluoxetine are also probably possibly useful. So one may ask that we know that in an otherwise patients, you may think that these SSRIs and SNRIs may worsen motor symptoms. But the studies have shown that the motor symptoms are well tolerated with these drugs and we can safely prescribe them. And other question is that whether starting an SSRIs with a MAO-B inhibitors is safe or not. Whether it can cause a serotoninergic syndrome or not. Yes, there is a theoretical possibility, but it is usually very rare, less than 1% only. So Actually, in clinical practice, we can safely prescribe an SSRI or SNRI with MAO-B inhibitors, though we have to monitor them. And other non-pharmacological options available include repetitive transcranial magnetic stimulation, CBTs, and electroconvulsive therapy. We can offer CBT delivered in person or via telemedicine, and it can be used as a monotherapy or in conjunction with the antidepressant. And psychosis is very common, and it can manifest as hallucination or delusion. And among the hallucination, visual hallucinations are common, but other forms of hallucinations are still present. And usually they present as passage hallucination or presence phenomena, as Dr. Sirisha mentioned. And delusions are not yet common like hallucination, but it can occur in presence of severe cognitive impairment. And they can present as spousal infidelity and present like the feeling of intruders in the house. And we should remember that the presence of hallucination may not be always related to the drug intake. It may be an indication that the patient is developing a cognitive impairment. So the risk factors, the disease itself, the increasing age, PD medication, and the developing cognitive impairment, and existing disorders like mood, sleep, and the visual impairment. So how to manage? So we need to manage the medication first. So the question is which one to discontinue first. So there is an order. So we remove anticholinergic first, followed by amantadine, followed by dopa agonist, MAO-B inhibitors, and we remove levodopa last. And we should always look for triggers like any infection or any other things like any other new infection and all, and we have to treat that. If the patient is having borderline cognitive impairment, you can consider adding rivastigmine in that patient. So this is an MDS evidence-based guideline. So pimavanserin is considered to be efficacious and clinically useful in patients with patients with Parkinson's disease suffering from psychosis. But the clinically useful drugs are quetiapine and clozapine. But we know that clozapine usually require close monitoring. So the three useful drugs we have in day-to-day practice today is quetiapine, clozapine, and pimavanserin. And not to forget, ECT is also clinically useful. And the studies have shown that the motor deterioration with ECT is as likely as in any other patient with Parkinson's disease. Coming to the other psychotic manifestation, that is impulse control disorders. So what is impulse control disorder? It is the failure to resist an impulse drive or a temptation to perform an act that harms the individual or others. So the common prototypes are compulsive gambling, compulsive buying, compulsive sex, or compulsive eating. So it's usually common in with dopamine agonist, and it is seen in 20% of patients with the dopamine agonist compared to 7% in patients with levodopa. If one ICD is present, there is a 1/4 chance that that person will also have more ICDs. And usually symptoms may not be present in early, and usually it comes after 4 to 5 years of initiating dopa agonist treatment. Sometimes the patients may not have these four problems, or it may be a related behaviors, which include hobbyism, that is more preoccupation with activities like gardening, gaming, and all. Or it may be funding behavior, that is repetitive behavior, which is non-goal oriented, that is handling, examining, sorting, such kind of movement. And this is usually seen in association with levodopa rather than dopamine agonist. Sometimes it may be a dopamine dysregulation syndrome. So this is usually characterized by misuse of the medication or escalation of the dose. And it usually occurs with levodopa and subcutaneous apomorphine rather than dopamine agonist. So how to manage this? So treatment often involves lowering of dopamine agonist while increasing the levodopa. So we should always be aware that while you reduce the dopamine agonist, there will be a problem of withdrawal syndrome. So you can switch to long-acting oral drugs or patch, which may be associated with fewer ICDs. You can use off-label treatment like antidepressant or antipsychotics, and DBS can be helpful in reducing the dose of dopamine agonist. And there are some insufficient evidence for anti-opioids like naltrexone, and sometimes cognitive behavioral therapy can help. So coming to the other major aspect of non-motor symptoms, that is dementia. So persons with Parkinson's disease can have either normal cognition, they can present with mild cognitive impairment or dementia. So at the time of presentation, as high as 20% have mild cognitive impairment. The factors that impact cognitive decline include age, the severity of the disease, less formal education, male gender, and the phenotype like akinetic rigid syndrome, and the coexisting factors like depression, psychosis, RBD, etc. And treatment options are limited. We have only one FDA-approved drug, that is rivastigmine. And other options like memantine on studies have shown mixed results. Even for rivastigmine, the clinically meaningful improvement is quite less. That is only seen, improvement is seen in 20% of subject. And there is also a risk of worsening of tremor seen in these patients. So we need to sort out other options, like we need to encourage our patients for physical and cognitive exercises. We should encourage them to treat other things for psychiatry, like we have to treat the coexisting psychiatric symptoms, treat the visual and hearing impairment, treat the coexisting orthostatic hypotension, RBD, infection, and should avoid harmful medications. So saying this, let's see what are the sleep abnormalities in Parkinson's disease. So we have many sleep abnormalities starting from insomnia to excessive daytime sleepiness and most importantly, REM behavioral sleep disorders. So how to treat them? The first and foremost is sleep hygiene, and we should always optimize the dopaminergic therapy for nighttime symptoms, and we should address symptoms like nocturia and ICD in these patients, and we should avoid drugs that cause insomnia, and we should always ask the patient or encourage the patient to do exercises, because we have randomized controlled trial evidence that chronic exercise can improve sleep efficiency in this patient. If the patient is having RBD, we can ask them to take clonazepam or melatonin. If the patient is having restless leg syndrome, we can prescribe pregabalin, gabapentin, or dopaminergic drugs, though beware of the augmentation. And if the patient having a sleep-related breathing disorder, we can investigate for OSA and prescribe CPAP accordingly. So again, reiterating, insomnia, start with non-pharmacological therapy, sleep hygiene, exercise, and CBT. And among the pharmacological therapy, the drugs commonly prescribed are melatonin, doxepin, and management of the PD motor symptoms are important, and rotigotine is found clinically useful also, and treatment of sleep-related breathing disorders quite important. And for excessive daytime sleepiness, we need to find out the cause, and if there are some medications, we need to taper it off. And the therapies which has been found useful are modafinil, and a second-line therapy, methylphenidate, atomoxetine are tried. Caffeine may be sometimes useful. If there is OSA, we need to treat that. So I'm not going through the RBD as we have already discussed this. And let's come to the other major part of non-motor symptoms, that is autonomic symptoms in PD. So drooling is not a major autonomic symptoms. It is actually due to the hypokinesia of the oral phase of swallowing, and also due to the pooling of the secretion, and followed by the esophageal hypomotility. So as a first measure, as a short-term relief measure, you can ask the patient to chew a candy or a gum, and you can advise anticholinergic, knowing that it may cause some side effect. You can advise the patient to have atropine drops put under the tongue once daily, or can have glycopyrrolate tablet 1 to 2 milligram. And if it doesn't work, we can go for botulinum neurotoxin injection, which reduces the saliva production. We can first start with parotid injection, and if doesn't work, we can add to submandibular injection, which can be repeated every 3 to 4 monthly. And constipation is very problematic in these persons. So it is seen as high as more than 60% of the patient. It is due to the degeneration in the peripheral autonomic ganglia. So general measures like water intake, exercise are encouraged. And osmotic laxatives like PEG is quite efficacious, and it is clinically useful. Other clinically useful is lubiprostone. And probiotic and prebiotic, we have evidence from randomized controlled trials these days. Stimulant laxatives are required often, and it is efficacious but not as osmotic laxative. Stool softeners are not that much effective but can be tried, and we often use it in clinical practice. And urinary dysfunction, it usually starts with storage symptoms in the early phase and progress to voiding symptoms in the later phase. And usually the treatment include anticholinergic, but you should avoid it if there is urinary retention and should be cautious about the central anticholinergic effect. And the newer one like B3 agonist, mirabegron, is very much useful with evidence from a single small RCT, and it is useful in patients with overactive bladder. And for patients with nocturia, the primary aim should be to improve the sleep because sleep is a natural antidiuretic. And nocturia is an indirect clue that patients should be evaluated for orthostatic hypotension. And you should manage the off-period urge. And also in severe cases, you may even consider giving desmopressin to the patient. For voiding problems, one can try botulinum neurotoxin injection, and always non-pharmacological. One should not forget like bladder training, pelvic floor exercises, and other measures like posterior tibial nerve stimulation are sometimes tried. And orthostatic hypotension, it is quite prevalent, not in the late stage, even starting from the early stages in up to 15% of the patient. And sometimes postprandial hypotension is also seen in patients. So we should start with the non-pharmacological measures. We should identify and remove the aggravating factors. Sometimes just adjusting the antihypertensive will help. And then if it doesn't work, we can go for pharmacological treatment. So there are few drugs like domperidone and pyridostigmine. These are like without increasing the lying down blood pressure, it can help with managing orthostatic hypotension. So these are still off-label drugs. At a dose of 10 milligram thrice daily dose, domperidone can be helpful, but be cautious, it can prolong QT interval. And pyridostigmine, 30 to 60 milligram QID dose you can give. Diarrhea is a side effect, but sometimes may be helpful in a constipated patient. And other pharmacological measures are fludrocortisone and short-acting pressor agents like midodrine, but it comes with an adverse effect of increase in the supine blood pressure. So these are the non-pharmacological measures that we should advise our patient before starting pharmacological therapy. This you all know: small frequent meals, abdominal and leg compression, increasing the salt intake provided there is no risk of hypertension, avoiding diuretics, increasing fluid intake, and advising for rescue water whenever they're getting up. And some counter maneuvers whenever they are trying to getting up. So this should be advised to the patients and encouraged to practice in the daily life. So the drugs probably possibly useful in clinical practice are fludrocortisone and midodrine and roxydropa. So there are other non-motor symptoms, but because of the constraints in time, we will not be able to go through it. So to summarize, non-motor features are often overlooked, yet significant source of disability. And they are mostly unrelated to the dopaminergic cellulose and remain unaffected by dopaminergic replacement therapy. But we should know that a few of them, for example, anxiety, pain, and restlessness, cognitive difficulties may still be fluctuating and be responding to dopaminergic therapy. And early diagnosis and management improve the patient and caregiver quality of life. There is no recipe for treatment. It is like customization of treatment, and you should anticipate complexities when you manage non-motor symptoms, and it often needs a multidisciplinary team. Thank you.
Thank you. Thanks a lot, Divya, for a very nice presentation. And I think now all the panelists are there, so we can start with the question and answer sessions. And maybe Divya, you can start with the first question, chat box or the question answer if there.
Yeah, the first question, I think Dr. Dhruv can take that. How early in Parkinson's disease can we expect changes on the Trodat? Dr. Dhruv is here.
Yeah, hi. So I think basically it can be seen much before the motor symptoms come in, because as we all know, see what happens in a Trodat scan is what you are checking is you have this iodine 123 radioactive dye, which is basically binding to the dopamine transporter protein. Okay. Now we know that by the time somebody has motor symptoms of Parkinson's disease, they have already had about 70% of degeneration, more than 70% of degeneration of the dopaminergic neurons. So, but the only thing is that you would not advise a Trodat scan in an asymptomatic patient. I mean, no, it is very rare that, first, what happens is that when you have a patient with Parkinson's, let's say somebody with tremors, rigidity, bradykinesia, a Trodat scan is not usually done to diagnose Parkinson's, but it is used to rule out other similar conditions which can mimic Parkinson's. So it's very difficult to say because you would not be doing a Trodat scan in an asymptomatic patient. I will have to go through literature to see if there are studies wherein they have done Trodat scan on patients with only the prodromal symptoms. I mean, somebody who has a RBD or somebody who has a hyposmia or somebody who has, only anxiety and constipation. I don't think any of these patients would undergo a Trodat scan unless these patients also have a family member who already has Parkinson's disease, and then you are doing this. So, I think a Trodat scan, if done in such cases, would definitely reveal the changes. Let's say you have a patient who has a family history of Parkinson's disease, a genetic Parkinson's disease, and you do it in an asymptomatic patient, you would see the changes because this is
Uh,
already you are checking a
Thank you. I think
molecular.
Dhruv, you have made the
Yeah,
point
molecular.
very clear. You have made the point very clear that even in asymptomatic stage, if the patient is Parkinson's disease, you can get a Trodat positive. But
Yes,
as
yes,
he has
you can.
said, there is no reason unless until we have a clear guideline to go for
Yes,
the Trodat. So I think we can
sure.
go to the next question, Divya.
Yes.
Yeah. So what should be the drug of choice in elderly above 75 years, Dr. Ajit? What would be your drug of choice for an elderly above 75 years?
Levodopa.
And what are the options if their motor symptoms worsen despite adequate doses of levodopa? Dr. Sahil, would you like to take that?
I would like to first optimize the medications only. DBS has also been tried, but in my experience, more than 70, the results are not that great. So I'll be little conservative in that. And we can try other options, apomorphine infusion. But first and foremost, we have to optimize the medical therapy and see what other drugs which can be tried.
Yeah,
We don't
maybe
know
the
how much
newer.
levodopa the has been tried, and we will see the prescription and decide accordingly, I think.
I think this Ajit has very nicely said in his talk for all the residents, and that you can start pramipexole in young onset, but with the LEAP study and other latest literature, I think levodopa still stands for any age group, provided the patient has significant functional disability and irrespective of the age. So let us go to the next question, Divya.
Yeah, is IV amantadine available in India? No, it's not available in India.
Sirisha, you want
Okay.
to add? Sirisha, you want to add quickly
Yes, sir.
something?
Sir, even the advanced PT, I have a comment. The
Please.
saying is that, like, if above 75, if there is a issue with a drug, where the benefit is less and the harm is more, particularly in elderly with all the associated complications, the dictum is to come down on the medication, because now it is the shift is more to a rehabilitative and much more degenerative and much more advanced. Yeah, as ma'am is mentioning, IV amantadine is not available in India.
So next question, please, we can take.
Maximum dose of levodopa. Dr. Ajit, would you like to take that? Maximum dose of it.
You can go up to 2 grams. 2000 milligram is fine enough. So
Perfect.
people have gone up to 25 to 30 milligram per kg. So for a 70 kg man, you can go up to that dose.
That answers the question. We go to the next. I think Ajit, thank you.
Okay. When should we switch to Syncapon from Syndopa? Dr. Sirisha?
When there is severe dyskinesias, which are intolerable, so now we want to come down on the dopamine side effects. In that case, we switch over from Syncapon to Syndopa. Intolerable dyskinesias.
Yes. Okay. What is the mechanism of double dyskinesia on and off stage?
Yeah, particularly.
Yeah.
You are asking.
So some patients.
Particularly.
Yeah, go
Yeah,
ahead.
if at all, the mechanism is very, very complex. It is like the postsynaptic receptors undue sensitivity to the dopamine is a theory. So this can be a variable. It can be peak dose or it can be double dose.
So to very simplistically, there are three levels where the dyskinesias can be modulated. the cortical, the presynaptic and the postsynaptic. So basically what happens as the degeneration for the residents, as the degeneration is continuing, there is less of storage of the levodopa which is possible in the presynaptic neurons. So immediately as the levodopa comes, it just flushes out. And when there is a need, there is no more levodopa available. So suddenly there is an on and suddenly there will be an off. So this is at the presynaptic level, but at the postsynaptic, as she has said, there can be super sensitivity of the receptor, though suddenly they may behave erratically. So this is how you can have several dyskinesias, patterns of dyskinesias. And sometimes because of this D1 receptor, so that as the receptor gets super sensitive, so they may behave erratically and patient may have dystonias. Because one of the question linked this question was how they can have dystonias. So I think with this, let us move to the next question, Divya.
Yeah, Dr. Dhruv can take this. There is a patient has non-motor symptoms and no motor symptoms. I'm just putting it brief. So how do you like to confirm or exclude Parkinsonism at this very early stage? There's non-motor but no motor, and which biomarker is available commercially?
I think Dhruv has partially answered. Maybe Dhruv,
Yeah.
you again quickly.
I think that was answered because I think practically speaking, I mean, there may be many research molecules or other things, but the point is that if somebody has, premotor or non-motor symptoms, so you could do a TRODAT scan, number one. Second, you could also basically see if there is some family history and somebody already having Parkinsonism in the family and directly go to a genetic test. So these are the two practical things which are recommended in this thing. Research wise, I mean, there are many things you could do. You can do, biopsy and other things, but which are not practical on a day-to-day, in a day-to-day scenario. You could also do a cardiac MIBG scan, sir, which basically shows the post-ganglionic this thing, which is commercially available. So you could differentiate between, Parkinsonism and a normal patient, Parkinson's disease and a normal patient.
Okay, so how long does DBS effect last, Dr. Sahil?
10 years, but now there are studies they are seeing up to 25 years, but 10 to 12 years, many studies have documented now. So I'll say 10 to 12 years.
Yeah. So does changing the target to GPI help if psychosis is present before DBS?
There are studies which suggest that ST and DBS causes more psychiatric and cognitive problems. But we don't know exactly. There are whether there is like bias in the studies, proper recruitment and other things. It's not entirely clear, but yes, there is a suggestion in the literature that GPI is better if neuropsychiatric effects are present. But it depends on the center. What we are doing more of STN.
Yes. Okay.
Dr. Divya, which are the preferable antidepressant and antipsychotics? I think you have covered that, but you could just name the antidepressants or antipsychotics you would prefer in an elderly.
Okay, sorry, so I was
Quickly, Divya,
raising
you
my
have
hand
10
for the
seconds.
previous question also. So for the antidepressant in elderly, SSRIs are still the first choice. So you can choose escitalopram, citalopram, and venlafaxine or mirtazapine, especially if the patient is having a weight loss or insomnia, mirtazapine can be a choice. So any of these you can start with low dose and gradually titrate. And in that previous question of PD psychosis, probably if the patient is having a medication-induced psychosis, maybe an STN still can be considered. Even as Dr. Sahil said, we don't have the clarity, but
yeah, and then I think
Dr. Sahil, the role and indications of focused ultrasound therapy, how does it compare to DBS?
We don't have much data, but it is a form of lesioning therapy. DBS is now well established. And for the one caveat is that focused ultrasound cannot be done bilaterally. It has to be done at a staged procedure. And we don't know the long-term results. It's just a form of lesioning, non-invasive, and very costly as compared to DBS.
Okay. So for an elderly patient with tremor-dominant PD, which drug to give for tremor if it isn't adequately responding to levodopa? Dr. Ajit, would you like to take that?
Elderly means what would be the age?
Maybe 70 plus.
Yeah, elderly.
So I think I will just
Acetane will like triaxiphenidil is a good one, but then that as age advances, the cognitive side effects are tremendous, and they don't tolerate this. But also, then if it's like between 50 and 65, we always try triaxiphenidil on top of this, which will give you a good result to the tremor. But beyond that, it may be difficult. They may not tolerate.
I think most of the elderly by that time have don't really have that much of tremor in the forefront.
And I think Divya, the most important point for this is that probably we should know that how what dose they are using, because many times tremor responds to a higher dose than rigidity and bradykinesia. So we may increase the levodopa dose, and that might only help. So, and what Ajit said is perfectly correct. If younger patient, you can try hexaphenidyl, but again, levodopa, if you are trying, if you can increase the dose, and that helps the tremor very often. So we can go to the next.
I think pramipexole helps tremor much more than levodopa, but I have found it's a very good
the issue is there will always be a debate whether to use triaxiphenidil or whether to use agonist, or you go for levodopa only. So many of the people, they do prefer purely levodopa. So let us go to the next question.
Okay. Is there any logic in starting amantadine prophylactically to prevent dyskinesia?
No, I think there is no logic as such. As I said, in dyskinesias, usually there are at three levels. The cortical level, where there is a excessive glutamatergic, because the dyskinesias are not only because of the hyperdopaminergic or dopamine super sensitivity, but it is also because of non-dopaminergic transmission disorder, the transmission plasticity, and one of them is glutamate. And of course, with amantadine acting at least by three mechanisms, with one of them being anti-glutamate. So it is not useful probably to use it just as a prophylactic. So better to use only when it is needed.
Yeah, Dr. Divya, which antipsychotic can be used safely in a patient with Parkinson's disease who developed neuroleptic malignant syndrome on olanzapine? So I think you have beautifully covered that. You can just name the drugs one of time.
So the only three drugs which we can use safely are clozapine, quetiapine, and pimavanserin. So for the ease, you can start with quetiapine or pimavanserin if available, and clozapine require close monitoring. Never use olanzapine or other drugs.
Yeah. In fact, pimavanserin takes some time. It takes 4 to 6 weeks to act. So if you have time and the hallucinations or psychosis is not that bad, you can still go on. But for a quick effect, I think quetiapine and clozapine will be better. So can the visual hallucinations caused by levodopa, is it reversible? Visual hallucinations caused by levodopa reversible?
I don't know actually.
So I will just take that. So when there is hallucinations or visual hallucinations, and you have some other drugs. So as Sirisha has already discussed, we can reduce one by one, like anticholinergic, amantadine, and other things. But if there is something which you feel is more because of levodopa only, then one way is just to start antipsychotic before you increase the doses of levodopa, because usually visual hallucinations or the onset of visual hallucinations, which may be related to the disorder itself, and they are a quite ominous sign. So maybe first trying to preserve the trying to prevent the psychosis, and then increasing the dose, because even reducing the dose can help get rid of the hallucinations if it is not disease related per se, or if it is purely levodopa related, provided you have ruled out all the other drugs, all the metabolic conditions, all the other infectious or any other systemic or any drug related cause. That has to be ruled before you label as. I think Dhruv wants to chip in. Yeah, Dhruv,
just a quick point, because I was speaking on diagnosis. Somebody having hallucinations, visual hallucinations early in the disease, the diagnosis of PD has to be questioned. It may be DLB for all you know.
Correct. Perfect.
Something that red flag.
Yes. So if it is early, probably if it is within 1 or 2 years or 3 years of the disease onset, then of course that is something you have to question whether you are dealing with DLBD. Perfect. Next question, Divya.
Can Trodat differentiate typical versus atypical Parkinsonism, Dr. Dhruv?
Yeah, I think definitely it can differentiate, because Trodat, if it is Parkinson's, will usually be asymmetric. And but sometimes you have these conditions like PSPP, wherein you have asymmetrical Parkinsonism, but it eventually evolves into PSP. So purely Trodat will not be a good choice to differentiate typical, atypical, but Parkinson's versus non-Parkinsonian tremor or other sort of conditions, you can use a PET scan, which will be more useful for atypical as compared to, typical.
I think Sirisha wants to comment. Sirisha?
Sir. So this is about the previous question. Normally, like,
Yeah, go ahead, please.
just 1 second, sir.
The psychosis one, you want to add something there? Or
Yes, sir.
Please,
Sir,
please.
actually, like in our practice, we do see that the dopamine agonist also can cause
Yes,
some amount
yes.
of psychosis.
Correct.
But once we stop it, as rightly mentioned, it could be a part of the disease also.
Yes,
But
yes.
once it is because of the drugs, once we come down on the drugs, amantadine and all, it beautifully completely reverses. Now,
Correct.
giving it out whether the patient is completely very typical PD and not associated with any dementia in the long run,
Correct.
long follow-up also.
Yes, yes. So, do we have still questions left, Divya?
Yeah, just a few. Like, there's a lot of confusion between essential tremor plus and PD. Treatment is different. How do you approach?
Essential
So,
tremor versus PD.
yeah.
So I think Dhruv has very nicely told in his talk, we need to have bradykinesia, and then only you can clearly go for that. And that we had already summarized. So we can go to next question. We don't bother.
Dopa PET versus DAT scan. What's the difference?
See, I think as I said, see, DAT scan is going to look only into the dopaminergic, the receptors in the mostly in the putaminal area, whereas a dopa PET scan will look at the entire brain. So to briefly tell you, it can, it can also tell you about the uptake and metabolism in different parts of the brain. So what I mean to say is that a PET scan will be more effective if you are looking for a atypical Parkinsonism, where other parts of the brain are involved, like a frontal lobe or occipital island you want to look at. That is more preferable in a PET scan. But that's there are a lot of different, differences which shortage of time. I would like to say that a TRODAT is best to differentiate between Parkinson's disease and other causes of Parkinsonism, like a drug-induced or a essential tremor. And a dopa PET would help you more effectively in looking at other lobar these things also, like reduced uptake in the frontal lobe or the other lobes.
Thank you, Dhruv. So Sahil, you want to add something? Sahil?
I think the mechanism is same. One is that spectral tracers are different, and one is PET scan. Both are looking at the dopaminergic terminals only.
Ajit, you want to add?
As far as other lobes are
Among the
concerned, the
panelists
FP
here,
PET would be
how
better.
many of us have resorted to a dopa PET scan to differentiate a typical from an atypical PD? How many of us have? None of us would
Not
have.
recommended.
Not me.
It is not recommended. The
Essentially,
message should not go.
Yes, Sahil, correct.
That's it. If none of us have ever resorted
So I
to that
think we go
investigation,
to the next
we
question. I
know
think
the validity of that investigation.
Ajit is bang on. We go to the next question, Divya, please.
Okay, so hallucinations. Patient is having hallucinations after 14 years of levodopa 5 times a day. Hallucinations are not complex or fluctuating. I wanted to know if I de-escalate the drug, since he's on that, amantadine and pramipexole. So Dr. Sirisha, I think Dr. Divya has also mentioned.
So we'll go to the next
first you take out.
They
That's
already
it. So
answered.
take out
Sirisha,
amantadine
Divya,
first.
they have answered.
We should first
Fine.
take
Just
out
the last question. Does propranolol help in PD tremors? Can we use it as an add-on?
Ajit can chip in. Ajit.
No, it doesn't help.
Okay. So
with that, we come to the end of
There are
the
postural tremors. It may help to some extent.
the
tremors
yes,
are predominantly postural and not resting.
So
It may
I think
help in some
Sahil and Ajit both are correct, because as Ajit said, it may not help, but I think with some postural component it might help. But anyway, we have better drugs than that, and those drugs will be more helpful than adding another drug to the basket. So I think with all this, Divya, we come to the close of the session, and we thank Divya for taking all the 24 of questions very quickly, and our panelists for going through all these things. So we thank all the listeners, and hopefully
I think we had 170 delegates today.
Yes. So you have counted. I mean, counted means you have seen the screen. Good. So we close the session then. I think Dr. Ravi and Dr. Sanjay Bose is there, or I think they are still there. So
no, I really enjoyed it. It was very well attended program, and I think you have organized very well. Neeraj and Divya. I congratulate both of you because very clinically relevant questions. And PET and TODAT will depend on center and all, but the overall it is presynaptic uptake which we are looking at. So between typical atypical, it is very difficult to differentiate. So really, thank you all and very vibrant discussion. With that, I think we can close the session. It will be very useful if this is put up on uh, the website also for long-term referral for the members to see. But I hope the videos, if you all have taken the consent, then only it should be put up.
Yes, boss.
That
Correct.
only you should have. So thank you. With that, we can close the session. Thank you, Neeraj, Divya,
Thank you. Thank you, boss.
Thank you.
Thank you, sir.
everyone.
Thank you.
Thank you.